Good morning, online students. I am going to divide the physical assessment content into two narrations because there's quite a bit in this PowerPoint for me to cover. So if you will make sure that you have your PowerPoint ready, make sure you have your book. This is the book that we're using. We just got a new edition, the 7th edition. If you have the 6th edition, you will be able to use it. The pages may be a little bit different, but it'll be off just by a page or two, so you ought to be able to find it rather quickly. All right, so I'm going to get off of here and pull up the PowerPoint. Let's see here, and slideshow. All right. So, oh my goodness, Miss Candler, are you really covering all that? I surely am. But you're going to be impressed how fast I can cover some of those chapters, I believe. Okay, the first thing that we're going to cover, if you will look in your book, and this is a very, very good book in my opinion, the health assessment. I think you'll enjoy reading it. It's easy reading. But chapter 1, why are we not covering evidence-based assessment? Because we cover that in our lecture coming up, and we cover that in every single content. So chapter 1 will be covered throughout the semester. Number 2, cultural competence. We also will cover that whenever we are covering culture in the summer, plus we do it in every single lecture. So, hey, I've already went through 2 chapters in 2 minutes. I am good. The only thing that in that section that I want to draw any attention to at all is on pages 6 and pages 7. And it talks about collecting 4 types of data. Okay, I do want to go over that just a little bit. Because you need to know the difference between a complete, a focused, a follow-up, and emergency. And if you think about a complete, you're going to do a complete health history and a complete health exam. So if you think about the settings that you would do that, that's going to be like home health when they are initially admitted and you do that complete head-to-toe assessment, acute care hospital, certain jobs, insurance companies do that when they're getting ready to give you insurance, hospice. Pediatric clinics, when they first admit you, will do a complete health total history. So a physician for the first time seeing you may do a complete health history and physical exam as well. What about a focused or problem solving? This is something that's limited and concerned with one problem. Well, we think particularly like the ER, the specialty units, but really it could be just about anywhere. Think about a patient who's been in the hospital for 2 days post-op, and you go in to check them, and they are starting to cough a lot. They're spitting up green stuff. They've got sputum. Then all of a sudden, you're probably going to want to do a focused assessment on the respiratory system. So even in the hospital, at times you may switch your assessment to being totally focused or problem-centered. Follow-up, evaluating the status of a given problem. Usually this is a short-term problem, but it could be a chronic health problem as well. So a lot of times we have a lot of follow-ups, and that is just what it means, going back in and evaluating the status, making sure you're doing okay. And then the last is emergency, of course, and that's when you have rapid collection that's compiled concurrently when you're doing life-saving measures. And of course, we think of the ER setting when we think of that. So you do need to know the 4 types of data. If you think about those, they're pretty self-explanatory. So the rest of that, again, chapter 1 on your own. Chapter 2 we cover throughout. Chapters 5, 6, and 7 will be covered in nursing theory with Dr. Ball. And chapter 10 and 11 will be covered in nursing theory throughout the program. So holy moly, we just went through several chapters, or I'm going to claim it anyways. All right then, so let's get started with the content I'm going to be covering, which starts in chapter 3, the interview. Okay? And as I put on your objectives, no, not the movie. Okay, the interview is the first part of the data collection. It's during the interview that you're going to collect 2 types of data. And if you'll remember the 2 types of data, and this is on page 27 in your book if you want to follow along, we've got subjective data, which is what the person states or the significant other or someone else. So subjective data is states. Objective data is what you observe. So I remember that real easy by SSOO. Subjective states, objective observes. Okay. So what's the key to a successful interview? Well, you've got to know what type of data you are collecting when you're doing an interview. And what are you going to be doing? Asking questions. So mainly this is the subjective part. Okay. So we're going to be gathering data. It's going to help support why they are coming in and hopefully decrease duplication of information from caregiver to caregiver. Now, you're going to have to establish a good rapport and trust, and fortunately, nurses are still ranked as being one of the most trusted professions. You've got to include the patient. You can't just sit there and ask questions with your head buried into a computer while you're sitting there frantically typing in the information. You've got to interact and have them part of that. You've got to have eye contact. And then teaching. And we all know that teaching's got to include the patient's participation. It can't be just what you want. The patient's got to be on board as well. When we look at the process of communication, and this starts on page 28 in your book, it talks about sending, receiving, internal factors, and external factors. When we think about sending, we think about verbal and nonverbal cues, right? Which one's more reflective of your true feelings, verbal or nonverbal? And you should have picked nonverbal. That's right. That's why we watch the posture, the gesture, the facial expressions, the eye contact, the voice tone, because those are the things that really tell us how the person is communicating with us. Now, unless you understand each other, I've got news for you. No communication is taking place. And sometimes you may feel that, hey, that went wonderful, and only to walk back in the next time and the patient doesn't have a clue what you were talking about. So you've got to make sure that the information went across like you wanted it to. Receiving. A mutual understanding. Did you understand and did they receive the message that you wanted them to receive? Internal factors. This is things like a genuine liking of other people. If you don't have a genuine liking of other people, you may need to consider changing your profession. Empathy. If you can't view the world from other people's feelings without criticism, you may want to change your profession instead of you may be a redneck. Ability to listen. Active listening. Boy, that one's hard, especially when we are so pressed and you've got so many patients and you're going from room to room. The ability to sit there and actively listen to what your patient's really, truly trying to tell you. Again, external factors are things like privacy, trying to decrease interruptions, making sure the physical environment is set up. Well, what do you mean by that? Well, the room temperature, the lighting, the noise, disturbances. Your book also talks about on page 29 distances and safe distances and the functional use of space. And it gives you some zones there with the remarks. You know, really, if we're 0 to 1.5 foot from someone, that's really in the intimate zone. Okay. So if you're needing to assess breath sounds and other odors, that's where you need to be. Someone's personal distance is about 1.5 to 4 foot. That's what we almost kind of visualize as our bubble. Then you've got your social distance. This is used for personal business interactions. And then you've got your public distance, which is about 12 feet. Okay. As far as looking at dress, you want to make sure that, of course, they're appropriately dressed. It talks about some note taking and the advantages and disadvantages of that, as well as recording, especially in the electronic health record. And if we think about note taking, whether we're doing it on paper, whether we're doing it in an electronic health record, it's really the same thing. It's wanting you to really make sure that you're focusing on the patient, that you don't totally break eye contact, that you shift your attention away from that computer or that paper and look at that patient occasionally. Or otherwise, you're going to miss out on a lot of nonverbal cues. Techniques of communication. Well, of course, you're going to introduce the interview. Hello, Mr. Smith. I'm Marietta Candler. I'd like to talk to you about what brought you into the hospital today. The working phase. This is your open-ended statements and questions. Tell me more about. Okay, that's always a good one to start out with versus your closed or direct yes, no, short answers. If you ask a yes, no question, don't expect anything else but yes, no. There's several responses here that you can get back. I'm not going to go over these because Dr. Ball will be covering all of those in psych in much detail. So what are the traps of interviewing? Well, if you look on page 32, it will give you the 10 traps of interviewing. And I know none of you are guilty of any of these. Number 1, providing false assurance. For example, don't worry, I'm sure everything's going to be all right. That one's really easy to get into if you're not careful. Giving unwanted advice. Well, if I were you, I would, right? Using authority. The doctor said do it, you're doing it. Using avoidance language. No, they passed on. Rather than dealing with the subject or using the correct terminology. Engaging in distancing. You know, I have a friend with vaginal itching and drainage. What should she do? Okay, when they're really talking about themselves. Using professional jargon. I'm going to listen to your breath sounds here. Boy, your vesicular breath sounds are clear. Let me listen to the bronchial vesicular breath sounds. I hear no adventitious sounds. They will not have a clue what you're talking about. Using leading or biased questions. You don't do drugs, do you? Now, what's that do? Once you word it like that and put it to them like that, they are not going to say they did if they did. They're not going to say they did even if they did. Talking too much. Listening more than you talk. And I know we've all heard about the wise old owl. There was a wise old owl who lived in the oak. The less he spoke, the more he heard. The more he heard, the less he spoke. Why can't we all be more like the wise old owl who lived in the oak? So listen to your patients. Interrupting. Man, we may think, you know, and we know these older patients come in that really want to tell their stories. But we got to be very careful about cutting them off because sometimes you can come across as rude, impatient, being rushed, and the patients will pick up on that. And then the last trap is using the why question. Why did you stay with him? Now, that puts people on the defense, a why question. So it's very normal in preschoolers. In fact, they ask about 400 why questions a day. But in the adult, we have to be very careful about using the why questions. Why'd you wait so late to come in? Well, that puts someone on the defense. Okay. What about closing the interview? Well, always end gracefully. Mr. Jones, do you have anything else you'd like to talk about before I leave? Do you have any concerns about anything we have discussed today? Right? And then give a summary, a final statement of what you and the patient agree that the health state is. Okay, and last but not least, always thank the client for their time and cooperation. In the book, you're going to find several sections at the end of each one of these that have developmental considerations. We will be covering this extensively in growth and development. So I'm not going to spend much time on that. All right, so chapter 3 is down. Boy, we are doing good. Chapter 4. Now again, this is the complete health history. So now we're still gathering largely subjective data. The components for this on chapter 4 starts on page 49. Okay, and the first section there is biographical data. The first thing it talks about is we're going to be gathering source of history and data about the patient. So the source of history, we're talking about the reason for seeking health care as well, the present health and history, the past history, the family history, the review of system, and the functional assessment of ADLs. Now I'm going to go over each one of those. When you're doing this, don't be caught up in the temptation is a good word, to fill all this out on yourself, hand it to your partner and say, here's my part. Because if that partner didn't look at that really good, sometimes they may not have seen that you, had your tonsils out at age 5 or that, you've got a history of chronic ear infection. So your ears probably have scar tissues in them. And then they get into the actual time when they do the assessment and start saying, well, this is clear and this is clear. So you want to be very careful. Make sure you are actually asking these questions. to someone. Now, your partner, again, when you get ready to do your health history, can be anyone over 18 years. It can be someone that's in the class. It can be a partner within the class, or you can pick someone else to do it on. Your write-up on your partner starts here. This is what has to be typed. So if you look, I told you you'd have two separate things here. One of them was the actual grading tool, and that's what we're going to look at now. The grading tool for the comprehensive health history and physical exam. So you can look at number 1, accurately document all the components of a comprehensive health history. Biographical data, source and reliability, and reason for seeking health care, 5 points. Present history of present illness, 5 points. Past health, 5 points. Now, why is the genogram, the review system, and the functional assessment worth 10 points? Well, you're fixing to find out. You do twice as much work for those, okay? So, the first section of your paper that you're going to write up includes this part. This is the comprehensive health history that you must do on your partner. You must write it up, and you must turn in as part of your paper. So there will be 2 parts to the paper you turn in. The comprehensive health history and the comprehensive head-to-toe physical exam. So let's go over each one of these. The biographical data, source of reliability, and reason for seeking health care that's worth 5 points. The biographical data is very easy. Again, this is on page 49. If you look down there, it says you're going to put their name, their address, their phone number, their age and birth date, their birthplace, and that will be city and state, their gender, their marital status, and if they have a partner, race, and that would be, if you look in your book as far as race, usually that's either American Indian, Asian, Black or African American, whichever they prefer to be called, Native Pacific Islanders, and White Caucasian. So those are your major groups of race. Then your ethnic origin is either Hispanic or non-Hispanic. Occupation, you want their usual and their present, because they may usually be a nurse, but they become disabled within the last 5 months, and you would need to know that. And then last thing there is the source of the history. That is who you are collecting that information from, and are they reliable. So some examples it gives you on page 49 in your book is the patient herself, who seems reliable. The patient's son, who seems reliable. Mrs. Somebody, the interpreter, who does not speak English. So you want to make sure you're putting the person, comma, and if they seem reliable or not. Okay. All right, so that takes care of the biographical data. Easy, easy peasy, 5 points. Okay. Then the next section, oops, sorry about that. I didn't have that up. The next section is reason for seeking health care. The reason for seeking health care. And this is on page 50. This is a brief statement in the patient's own words that describe the reason for the visit. Now remember, when you're looking for signs and symptoms, a sign is objective data, symptoms are subjective data. Right now we're doing all subjective data, so we're looking for symptoms. It is 1 or 2 symptoms or signs in the duration. So we're going to be looking for primarily, again, when we're doing this section, for symptoms, and when we do the head to toe, for signs. Examples would be vomiting and diarrhea past 48 hours or 24 hours. Needs yearly physical for work. The worst headache of my life past 3 hours. And again, there are samples, statements on page 50 over in your right-hand column. Avoid translating into medical diagnosis. You don't write kidney stones. For complaint of kidney stones last 24 hours. You would write complaint of left flank pain, 24 hours. Now, for you guys, this is going to be very easy, because what you're going to write is need a physical for school, completing a physical for completion of the course. I mean, it's whatever you want to write there, the person that's volunteering to help you, but it will be a short statement. Pick someone who is healthy when you do this, relatively healthy. All right. Then we're going to go to pages 50 and 51 and do the present health and history or present illness. Now, again, in a well person, this is a very short statement about the general health of the person. So the example would be, they state their health is in excellent condition. They state they feel healthy today. They state I feel good, but I'm not very active, whatever their statement is. The ill person, this is going to be a much longer statement. You're going to have to go into the location, the character and quality, the quantity, severity, the timing, the setting, any aggravating and relieving factors, associated factors, and the patient's perception. It tells you on page 50, 1 to use the PQRST format. So you would want to use that. So please read over the PQRST format. An example I've written there is, please tell me about your headache. If they come in and said, you know, I've had a headache. Let's say that was their statement. Worst headache of my life. What was that example we used? Worst headache of my life past 3 hours. Then when I got ready to do the present health and history on that person, then I would say, please tell me about your headache from the time it started until you came here to the hospital. And then you would be looking at things like location, character, quantity, severity, timing, setting, aggravating, relieving factors, associated factors, and their perception. But again, for this assignment, it should be a very general statement of their health. And if you pick someone who's healthy, it should be short and sweet. All information that you put is confidential. This will not be shared with anyone or read by anyone else, so it's okay. Pages 51 and 52. This is their past history. And if we look on pages 51 through 52, you will follow this exactly like it is in the book. So read each one of these in detail and simply answer the questions. For example, childhood infections or illnesses. Measles, mumps, rubella, chickenpox, pertussis, strep throat. Avoid recording usual childhood illnesses. Because an illness common in the person's childhood, mumps, may be unusual today. Polio is another example. Ask about serious illnesses that have sequelae for the person in later life, like rheumatic fever, scarlet fever, polio. So they need to actually list every childhood illness that they know that they have had. If they cannot recall, you need to put that. Accidents and injuries. You want to know about auto accidents, fractures, penetrating wounds, head injuries, especially if associated with unconsciousness and burns. Serious or chronic illnesses. You want to ask about asthma, depression, diabetes, hypertension. If they don't have any, then you put denies asthma, depression, diabetes, hypertension, heart disease, HIV, hepatitis, sickle cell, cancer, or seizure. Now, you can also put there, if they're completely healthy, denies all chronic illnesses. Hospitalizations. You want to, now this one, be very careful if they put in the hospital, because you've got to put the cause, the name of the hospital, how the condition was treated, how long they were hospitalized, and the name of the physician. OB as operations would be the type of surgery, the date, the name of the surgeon, the name of the hospital, and how they recovered. If they do not recall some of that, then you put they do not recall. And then, of course, the OB history is recorded as gravitas, terms, preterms, abortions, and living. And it goes into what each one of those mean. Immunizations are in the next page, on page 52. Be sure to read over that. Their last exams, you want to record that as well. When you get into allergies, make sure you're noting what the allergy is. Is it a medication, a food, or a contact allergy, and what type of reaction they have. Current medications. Medication reconciliation is a comparison of their current meds with their previous list. You have to do that with every hospitalization and every clinical visit. This is really important to do when you're transferring patients between nursing homes and hospitals. You always have to do a medication reconciliation to make sure those medicines match and something doesn't get lost. All right, so again, easy peasy section. All you got to do is follow that. Looking at the family history on page 52 and 53, we're going to do a genogram, and you will be required to draw the family tree. This is not that difficult to do, and I will do a PowerPoint over how to do a genogram. The grandparents is what you've got to start with on both sides. Then do the parents, and then the client and siblings. Now, if you want to do the spouse and children, those are optionals. You're welcome to. But the requireds are the grandparents on each side, the parents, the client, and any siblings. That's what has to be on your genogram. Okay. Now, if you look on the genogram of the example that's in the back of your book on page 785, let me get back there too. This one would be more like the one you're going to draw versus the one on page 53. It's much more detailed. The one back here has the grandparents at the top, then it has the parents, and then it has the actual patient and sibling. That is all that you would have to do. Look there on the side and note they have done a legend. The circles are females, the squares are males, the deceased are the colored in, and if it's not, then they are alive. If you look here, they put their age, and they put any chronic illnesses that they have below that. So you will need to do that as well. So if you follow the example on page 785 for your genogram, you'll be fine. You cannot write this out. You have to do a genogram. All right. Or it's also called, you may hear it called a pedigree. Okay. And again, I am going to do a PowerPoint on that. So that brings us to the review of systems on pages 54 through 56. This is the head to toe part. So now, again, the head to toe, but subjective data. A common mistake by your novice practitioner is to record some of your physical findings or your objective data here. Do not be tempted to do that. This is subjective data, so you're still asking all the information. Remember, this should be limited to what the patient states or subjective data only. So, example, if you were doing the head, no headaches, no head injuries, no dizziness, no syncope or vertigo. Well, how did I get that data? I had to have asked them, do you have any problems with headaches? Have you had any head injuries? Have you had any dizziness, syncope, or vertigo? Now, on here, you just can't put in here denies problems, because I have no idea when you put denies problems what you ask them about. You have to list them specifically what you ask about. You can put denies, you can put the word no, but you do not do complete sentences. It is written, this is an example of how you would write that up. Okay. Now, when we're getting ready to do the review of systems, if you look on the bottom of page 54, it gives you the first thing you're going to do is a general overall health statement. And you have to do that starting your review of systems. This would be about their present weight. Have they lost or gained weight? Over what period of time? Are they dieting? Have they had fatigue, weakness, malaise, fevers, chills, sweats? So you would want to, that's what you're going to start with. Then the next section is your skin. And we'll go over just the skin part to get you started so you know what to do. If you look at the skin, it says you ask them about skin diseases. Have you had any problems with eczema, psoriasis, hives? Have you noticed any pigment or color changes? Have you had any changes in moles? Have you had any excessive dryness or moisture problems, itching? Have you had any excessive bruising, rashes, lesions, anything with the skin that I should know about? And then you would go back and you would document that, okay? And then you would go into the hair. And every time it says health promotion, make sure you ask about that and you document that, okay? So you go through every single system. It is quite long, as you can see. It goes through page 56, okay? So you will do each and every one of these and ask each and every one of these questions and document it. Not hard whatsoever, just a little bit time consuming. All right. Then we go to the functional assessment. The functional assessment would be about asking about their activities of daily living. This is on page 56 through 58, and it ends with the perception of health on page 59. Okay? So if you're looking on page 56, functional assessment, and you have to include all of these. If you look at the example in the back of the book, which we'll go over here in just a little bit, it has left some of these off. If you leave them off, you will not get full credit for this section. So when you get ready to do the functional assessment, you will go to page 56 and 57, and you will ask all of these questions, starting with self-esteem, self-concept. Then you will go down and ask questions about activity and exercise. Then sleep and rest, nutrition and elimination. And look there, you'll have to do a 24-hour calorie count, what they ate the last 24 hours. interpersonal relationships, spiritual resources, coping and stress, personal habits, alcohol, illicit street drugs, environmental hazard, intimate partner violence, and occupational health. Make sure you do every single one of those sections, that you put titles for each one of those sections. The last thing you will end with on the functional assessment is what's called the perception of health on page 59. You will ask the person questions such as, how do you define health? How do you view your situation now? What are your concerns? What do you think will happen to you in the future? What are your health goals? What do you expect from a nurse, a physician, and other healthcare providers? And you will just simply write out what they say. And that will be that part. Now, if you're doing a health history on a child, that's going to vary some. It gives you an example on page 59, starting if you were doing children, how each one of these sections would be changed up. Read over that, but you don't have to. I know that because we're only going to be doing it on adults, but please do read over that. When you get to page 64 and 65, it talks about the adolescent and using the HEEADSSS method of interviewing. And it gives you an example of what you would ask in each one of those sections on page 65. And this is very important and pertinent to ask adolescents about the home, their education, employment, their eating habits, activities, drugs, sexuality, suicide and depression, and safety. Because those are major reasons and health issues that we have with our adolescents, some of the major problems right now. Okay, so hang in there. It is not that bad. Let's go flip back to page 784. And there is actually a whole health history written up for you as an example. Again, example. You will have to write up your own because yours will vary a little bit. I've went over everything we want because this person actually has a health history problem and yours should be a healthy person. It goes through, starts on page 784 and goes through the functional assessment on page 787, ending with the perception of health. You read these, go by these as a guideline, but again, remember that you will be doing it on your patient and you will be including more information. All right, not that bad so far, huh? So, your assignment is going to be that you are going to write up again a comprehensive health history on your patient, on your partner, and the health history is due the day of your checkoff. So, the day that you do your actual turn in your assignment. So, if you do it on video and you turn it in, then you also have to go into the nursing practicum course and turn in your write-up as well. You will be writing up a head-to-toe assessment as well. Remember, there's two parts to this. So if you get out that grading tool again, comprehensive health history and physical exam, the first 10, 20, 30, 45 points is what I just went over. And I went over in detail everything that you need to put in that. So if you put everything in that, that's an easy peasy 45 points. The next section, number 2, starts with the actual writing up of the comprehensive physical exam, and we'll go over that word for word. So your health history starts with assessment techniques and approaches, okay, to the client setting. And this is going to be starting in chapter 8, okay, on page 115. You're going to be cultivating your senses. And we're going to be talking about each one of these, the setting, the equipment, setting up a safe environment, and the setting. When you're cultivating your senses, you're going to be using inspection, palpation, percussion, and auscultation. Those are the 4 major skills that we're going to use. Now, these skills are usually performed in this order, one at a time, except when you're doing the abdomen. When you're doing the abdomen, you always inspect and auscultate before you palpate and percuss. Inspection. Now, this is a little awkward at first, so think about it. You feel like you're almost staring someone down because you're looking for those nonverbal cues. You're looking at their skin real good. So you're doing a concentrated watching of that person. You're looking at every body system, and this always should come first. Inspect, inspect, inspect. So in order to inspect well, you have to have good lighting. You have to have good exposure to that area. And you have to use good instruments. Sometimes you may have to use an otoscope, an ophthalmoscope, a pen light, a nasal and vaginal specula. No, you won't be doing that. All right, palpation. When we think about palpation, using your sense of touch, we can use this in our advantage by using a very calm, gentle approach. Anytime you get ready to palpate someone, you want to make sure your hands are good and warm. And you always want to do tender areas last. Light versus deep palpation is something that you need to be trained if you're going to be doing deep palpation, because you can actually cause more damage if you don't do it correctly. And your book talks about different parts of your hand being best suited for assessing different factors. If you look at page 115 in your book, it talks about your fingertips are best for fine tactile discrimination like swelling and pulsations. A grasping action of your fingers and thumb if you're wanting to know position, size, and consistency of an organ. The dorsal or back part of your hand is best for temperature. The base of your fingers is best for vibration. So that gives you probably didn't know your hand was worth so much and that each part of it could do so much. But it's very important that you know which part of the hands is best for what assessment technique. All right, so on palpation, just because I palpate someone, what can I find out? Lots and lots. Texture, temperature, moisture, organ location, swelling, vibrations, crepitations, lumps, masses, tenderness, pain. Lots of data can be collected simply by palpating. Percussion. Why in the world would we learn to percuss, Miss Candler? Well, percussion is very, very important. It's always available, it's portable, and it gives instant feedback. There's a difference between direct and indirect percussion. Direct is striking the hand directly when the body is in contact with the body wall, when your hand is. Indirect is using both of your hands. Now we're going to be striking the hand over the body. So it's tapping the patient's skin with short, sharp strokes. And what will this do? Elicit a characteristic sound or vibration. So if you look on page 115, it talks about your stationary hand. And let's all do this together. Hyperextend your middle finger and place the distal joint or the firmly against something. So right now you can put it firmly against something. It doesn't have to be someone's skin. It can actually just be on your actual desk or something. Now, percussion over a bone yields no data because it's a dull sound. Lift the rest of the stationary hand off of the skin or off the place that you're at. So all you should have 4 fingers up, your middle finger down, and that distal joint flat. Okay? Now, the striking hand, if you look on page 116, which is what I'm on, use the middle finger of your dominant hand. Hold your forearm close to the surface and do the tapping motion. Percuss 2 times in one location and move on. Now, a reflex hammer is a very good thing to do as well. So you can take a reflex hammer and do that over your finger, or you can take the middle finger of your other hand and do that. So that is percussion. Now, what do the sounds mean? If you look on page 117, it goes over resonant, hyperresonant, timpani, dull, and flat. All right. So let's do you know, okay? If you were listening over lung tissue, what sound do you think you would hear? Lung tissue. Lung tissue would be what we call resonant, okay? And what is resonant? Well, it's clear, hollow, and it's because you've got a lot of extra space in there. It's got a moderate duration and a medium loud tone. If you're listening over the stomach, that would be matched up with timpani, very soft sounds, almost sounds like a drum. Then you've got the spleen. The spleen is an organ. So over organs, we hear dull. Over organs, we hear dull. It's a very short, almost a muffled thud. Then flat is just what it sounds. Very soft and very short and very dull, just a dead stop flat. It is hard sometimes for people that start out to distinguish between the flat and the dull. The lung tissue, if someone has COPD, This would be hyperresonant. It's almost a booming sound. This is also normal to hear over a children's lungs. Usually about 8 years and younger, you can hear hyperresonance. So auscultation, when we get into auscultation, listening to sounds produced by the body, our stethoscope becomes our best friend. And do you know its features? Should be about 12 to 18 inches long. Any longer than that will actually distort sound. Earpieces, make sure you've got comfortable earpieces and they slope towards the ear. Now, does it magnify sounds? Does a stethoscope magnify sounds? No, it does not. What it is designed for is to block out extraneous background sounds and background noise, but not to magnify. So if you have someone who has a hearing loss, they actually have to have a intensifier put on their stethoscope. So it's easy to use but difficult to master. Why in the world would you say that? Because you've got to learn a wide range of normal sounds. You have to know what you're hearing and know why you're hearing it. The diaphragm, we know, is used, that's the larger part of your stethoscope, for very high-pitched sounds. So if you're listening to someone's breath sounds, bowel sounds, normal heart sound, you're going to press firmly. Now the bell is the smaller one. That is the soft sounds, the low-pitched sounds. I'm going to use it when I'm trying to hear murmurs, extra heart sounds, and I'm going to hold it lightly versus firmly. Okay, on page 118 in bold, it states, never listen through a gown. So if you've been doing that, stop it. It says, even though you see this on television, listening through clothes creates artificial sound and muffles any valuable sound of the hearts and lungs. Therefore, reach under a gown to listen and take care that no clothing is rubbing your stethoscope. Okay? The setting. What's the ideal setting? Number 1, warm and comfortable. Number 2, quiet and private. Number 3, well lit. Number 4, free of interruptions. Number 5, ideal positioning. Means you have easy access, eye to eye, like roll-up stools are really good for that. And that is the ideal setting. So what about your equipment? Well, the equipment, the key is to have the equipment ready ahead of time. Have it all laid out and organized. If you look on the bottom of page 118, it gives you an excellent example of what your table should look like. So the first thing you want to do on the day that you're getting ready to do this assessment on your partner is take a few minutes, set everything up, make sure you get all your equipment. The last thing you want to do is look at your equipment again, because before you say, I'm done, if you look back there and you see the tuning fork and you think, oops, I didn't use that. Oops, I'm not done. I need to use the tuning fork and check for vibration sense. So sometimes doing that last scan of your equipment again will keep you from losing points, because you will look over and make sure you used every equipment that's listed there or that is on your table. A safer environment. We want to have a clean environment. Let your stethoscope become a stethoscope. Simply keep it clean. Best thing to clean it with, alcohol pads. So keep it clean. Wash your hands. Wear gloves. There's certain parts of the assessment, head-to-toe assessment, you can do without gloves. There's certain parts you have to have with gloves. Use standard precautions when you have to. If it's wet and not yours, don't touch it. Transmission based. If they are in airborne, droplet, or contact precautions, make sure you are following those appropriately. Okay. The last thing that we're going to talk about before we end part 1 is the clinical setting. This is on page 121. It says the general approach. The best way to decrease anxiety for yourself, I'm going to tell you, practice, practice, and still practice. Hands-on. Explain everything you're doing. Don't touch a patient before you explain everything you're going to do. I'm going to have to palpate your skin. I'm going to have to palpate your head. I know it may not be comfortable at times. I want you to tell me if you feel any tenderness when I do that. I'm going to be percussing at times. That's when I will take my hand, lay it on your skin, and you'll hear this kind of sound. Okay. So you need to explain what you're doing. Again, this chapter ends with developmental competencies, and it goes over how to prepare each age group for a physical assessment. Again, I will be covering that in growth and development. All righty then. That takes care of part 1 of this physical exam. Thank you very much. An overview. If you have any questions or concern about how to do the comprehensive health history write-up, please let me know. That's worth 45 points on your grading tool. The next section we will start with is the actual physical assessment head to toe. Thank you.